Good day, everyone, and thank you for joining us for today's Behavioral Science Week webinar, Applying Behavioral Insights to Strengthen Health Equity and Impact. Today, we'll engage in a series of flash presentations to introduce you to the UNICEF Bird Lab and spotlight context-specific approaches to applied behavioral science being rolled out across regions and country offices around the world. As we proceed through the session, please add your questions and comments to the chat, and we'll reserve time at the end for an open discussion where panelists will respond to your thoughtful inquiries. And so without further ado, to kick off today's webinar, here is UNICEF Bird Lab Director, Ben Hickler. Next slide, please. And with that, Ben, over to you.
Thanks, Ray. Hi, everyone. Good evening, good afternoon, good morning. We are calling in from all over the world. I'm in Bangkok. We have colleagues in Dakar. We have colleagues in Nairobi. We've got colleagues in New York and Panama. I just want to say a few things about the Bird Lab at UNICEF. This is the Behavioral Insights Research and Design Laboratory, which is just a space and a community of practice we've tried to create internally at UNICEF to socialize key concepts and evidence and methods from the behavioral sciences in UNICEF's work. So we try to apply behavioral science to our internal operations as well as our programming and policy design. It's an inclusive and collaborative space. We work with all regions and are bringing new country projects on board every day. Part of what I want to do here in terms of setting the scene is just say a few words about how UNICEF approaches applied behavioral science maybe a little bit differently than some other organizations, given the challenging context we work in, humanitarian settings, low resource settings, low and middle income countries, and with sort of a rights-based approach. Next slide, please. Some of the things we do at the Bird Lab are normal global functions. With our network of regional nests or hubs or nodes, we strive to identify appropriate partners and convene thought leaders, policymakers, academics, pracademics, and practitioners to really systematically bring evidence to bear on some of the most pressing challenges facing the world's children. We are actively creating new trainings and tools for the ethical integration of behavioral science and insights from the behavioral sciences into UNICEF's work and our work with partners in terms of achieving results for children. And we spend a lot of our time with direct technical assistance and capacity building to try to institutionalize the ability to apply behavioral science to achieve results. And we really focus on contextualized, tailored, people-centered, participatory approaches to develop real evidence-informed, locally appropriate approaches to social and behavior change. Next slide. This is actually a bit out of date. So we have a lot of country projects, and I might not have really even introduced myself. My name is Benjamin Hickler, and I sit at UNICEF's Office of Research Innocenti, or UNICEF Innocenti Office of Research and Foresight. And I should just be clear and acknowledge that UNICEF is a large decentralized organization. So in many cases, some of our country offices or regional offices are the ones that are taking the lead in applying behavioral science in their social and behavior change work. UNICEF has a social and behavior change workforce that's between 450 to 500 full-time staff all over the world. And so the Bird Lab is more a chapeau or an umbrella or a ceiling, a room without walls to include all of these efforts and to really empower the intrapreneurs and pathfinders in our midst. But we do also provide a lot of technical assistance and try to create sort of joined up support from headquarters, regional office, and country level so that we can be more than the sum of our parts. Next slide, please. Very early on, there has been a lot of excitement around applied behavioral science, and especially given UNICEF's historical role in social and behavior change. But we quickly realized that it could not be used as a one-size-fits-all approach, a very narrow tool. We needed to make sure that we didn't end up approaching behavioral science like a hammer running around looking for nails, and that we needed to make sure that we took a problem-driven, locally appropriate approach. And we spent a lot of time making sure that we were getting the problem right before we decided what the best tools for the job were. So what we landed on, and a lot of this is actually about internal organizational habits and internal change, was a combination of the evidence and methods from the behavioral sciences with some sort of private sector methods like design research. And we created an approach that tries to be a bit nimble, extremely participatory, radically participatory, and very contextually appropriate, so that we can uncover actionable insights and involve people in defining the problems for themselves and developing solutions that are locally appropriate. Next slide, please. A few principles is that we really try to keep the people at the center of defining their problems and developing their solutions locally. We really try to take a systems view and make sure that we're not accidentally substituting an individual level solution for what's truly a structural or systemic problem. We try to keep our research really oriented towards timely and actionable insights. We do not create studies to sit on shelves. We create evidence to inform our programming and then try to measure to make sure that we're making a difference. And we try to take a really tailored approach to applying behavioral science to make sure that the solutions align with local values, that they're appropriate for the context, and that they're kind of viable and sustainable without constant inputs, so we don't end up with just a bunch of little pilots or projects. And then we put a lot of emphasis on experimental methods and quasi-experimental methods for testing solutions in context. And we really try to include an aspect of operational research or implementation research to complement our experimental design, so we know not only whether or not something worked, but we have some insights to why it did or didn't work, and if it did, what the mechanisms for change were. Next slide, please. Because there's a ton of different sort of process schema or frameworks out there for applying behavioral science or behavioral insights. And UNICEF works with a lot of different partners, the Behavioral Insights team, Ideas 42, just to name a few. We, for better or worse, had to come up with our own mnemonic even though it's all the same steps as most of these other processes. But we did really want to reflect that, one, we spend a lot of time on the definition stage. We try to make sure that we're clear about the program results that we're trying to achieve, and we're clear about the specific behaviors and the kind of results chain or theory of change, and how those behaviors lead to those overarching program results we're trying to achieve. And then we have this element of prototyping and design thinking when it comes to solution development, because we really want to broaden our aperture, think in terms of systems, and both in terms of where we're diagnosing the problems, but also developing solutions, instead of only focusing on simple, tiny tactics, focused on really, surgical nudges and things like this. We really wanted to make sure that we are addressing complex problems with systems of solutions. And we put an emphasis on testing our hypotheses using experimental methods. And then we want to make sure that when we find something that works, that we have built-in learning plans, so that when we're scaling, we're learning as we go, we adapt, iterate, and as we scale. Next slide. So that's about it from the global level. I just want to emphasize that the Bird Lab and UNICEF's overall approach is not about catalyzing a bunch of projects, even though that is happening. all of these projects are opportunities to build capacity, both of our workforce and of our governmental partners. So we're spending a lot of time trying to hook our local government counterparts up with appropriate academic or other institutional partners, non-governmental partners, so that we're building a country level capacity that's durable, that outlasts any one staff person, and that hopefully over time is transferred from the UN system to really strengthen the government's ability to do this work on its own. Which we're focusing a lot on mainstreaming a rights-based, problem-driven, iterative, and adaptive approach. We need to diversify the evidence base because we don't work in weird contexts, and yet the majority of evidence comes from Western, educated, industrialized, rich democracies. We spend a lot of time facilitating peer-to-peer learning and opportunities for South-South exchange. And as I mentioned, it's about these durable partnerships and institutionalizing this capability rather than catalyzing country projects. If you want to learn more, there's one of these QR codes. We have a website, though it's being revamped, and hopefully we'll have future opportunities to talk about it. But the good stuff is all in the regions and the countries, so I pass it on to the next speaker.
Thanks so much, Ben, for this great introduction to the Bird Lab. And we'll see many of these principles coming to life as our regional office and country office colleagues share their current approaches and strategic visions for applied behavioral science and practice. So sharing regional perspectives from around the globe, we're joined by colleagues across LACRO, WCAR, ACAR, and ISARO regional hubs. Joining us to start this morning is Jessica, representing LACRO. So next slide, please. And Jessica, over to you.
Thank you, Ray. Good morning, good afternoon, everyone. I'm here today representing our Alliance strategy, Marco, who prepared the slides, but unfortunately could join us today. So to share a little about the strategy we have here from the Latin American and Caribbean, we've focus our strategies in behavior insights, in human-centered design, interpersonal communication, and social listening mechanisms. So based on these strategies and also in three main principles like human rights-based, people-centered, and systems-oriented, we seek for system strengthening, for service improvement, and also community engagement. To do that, and to also try to work together with different organizations such as academy and faith actors and community engagement, we adopt the Latin American approach. So pedagogy of the present, scientific pensar, and the colonial thinking, and also participative communication. And next slide, please. So to understand this a little more clear, we have this, for example, big immunization challenge from UNICEF, that is the zero-dose children here in Latin America and Caribbean. So to face this big challenge, we apply human-centered design and behavior insight in the process, so we can affirmative research, community engagement, and also service provider improvements with co-creation of these providers, which is an important thing now in the immunization process, considering all the actors that is involved in this work. So with these strategies, with this Latin American approach, we can, for example, achieve some intermediary outcomes, such as increased participation, demand of services, trust in institutions, improvement of services, conductive policies, and also conductive communications environment. That is one of our goals too. So now we have a partnership with UniNorth University in Colombia to do all that, and also with the York University in Paraguay, and we are building partnerships with National University in Paraguay and Nicaragua and Honduras. So we hope to have this initiative very strong, more strong, and with more outcomes. So thank you, and back to you, Rachel.
Thanks so much, Jessica. We just love the approach that the LACR team is taking to synthesizing and integrating behavioral approaches with longstanding traditional cultures of things like storytelling, communication, community-led engagement, and so forth. And thanks for sharing that out. Next, we'll hear from Etienne from the Wakara region. Etienne, over to you.
Thank you very much, and very glad to present on behalf of the West and Central Africa region. So maybe let me reframe our overview more as a story that we are currently experiencing. And we would be also very happy to, if you have any suggestions, to share them with us so that we can learn together how to move farther on in the future. So we will talk about our vision, the challenges, our approach, and the work that Ghana and Burkina Faso are currently doing. But let me go to the beginning first. So we are seeking for new ways to go beyond providing knowledge, information, and persuasion with regard to health-related actions. And so we were asking ourselves, how might we experiment with behavioral science and human-centered design to offer more kind of a complementary way to achieve results for children, especially regarding immunization, health, but keeping it also anchored in the national context. So we co-created a vision that kind of focused on three key aspects. So it's change the environment, not the person. And I think this is really key, where BI and HCD offer so many opportunities in this regard. The second one is to collaborate for government ownership. And lastly, is to connect country offices in the region to generate more relatable examples that inspire and on which the other countries can then in the region build on. So we were very excited by this vision, but we realized that implementation is actually not that easy. So let me just name three challenges. The first is the lack of resources in French, because most of the resources are actually in English. The second is when it comes to trainings, we were thinking, how could we move quicker from theory to action and practice? And lastly, we realized that it's kind of impossible to have one uniform offer for demands and needs of 24 very diverse countries. So what we did was to establish this kind of spectrum that you can see on the slide to structure our offer. So on the left-hand side, it's more about developing resources that help colleagues and government counterparts to apply BI and HCD to our everyday work on immunization, simply as a way to enhance our view of the broader area of immunization health, but also beyond. And we co-created and iterated a lot of tools adapted to our region. One example is the EASE framework that we now use also in French. In terms of trainings, we opt for more hybrid models to learn by doing. So just recently, we had a training on behavioral design facilitated by one of our partners, Common Thread, where colleagues applied their knowledge to think about how to increase routine immunization. And on the other side of the spectrum, we currently have Ghana and Burkina Faso that implement a more kind of comprehensive process. So Ghana, together with Common Thread and the government, use behavioral design to prototype around easier wayfinding to vaccination centers. And in Burkina, together with the government, Nudge Lebanon, and the Busara Center, they use behavioral science to improve nutrition for pregnant women. So the idea now is that other countries can get inspired, build on these experiences, and replicate and adapt to their context. That's where we are currently in our story. I will stop here and look very forward to discussing with you. Thank you.
Thanks so much, Etienne, for the presentation. The Wakara Regional Hub is such a shining example of thought leadership, innovation, and the creation of knowledge-sharing platforms that break down silos. We really appreciate the growth mindset that you bring to our work and the spaces that you create where we can learn, grow, and exchange knowledge together. And now representing the Akaro Regional Hub is the Poland Country Office team. Anastasia Anaga, over to you for your flash presentation on applied behavioral interventions in Poland. Next slide, please. And Anna, over to you.
Thank you so much. First of all, I think we are a great example of how much assistance we got from Bird Lab. I think we are a very good baby of this initiative where we got, research assistance feedback on our initiatives, because by ourselves it would be very difficult to manage. However, we do run now 4 experiments in parallel, which informs us about how to approach and create demand among refugees. We can go to the next slide. Of course, it's a very challenging environment. We are not only working with one of the most vaccine hesitant population in the world, that Ukrainians are, but also 2 million of people that are relocating to another country. And they need to find the services, which again, maybe not always they even want or understand the importance of, but also they are not informed how to get them. And in addition, there is a barrier of health professionals that are Polish that cannot read the vaccination records of Ukrainians, overwhelmed and with the numbers of increased population in their country and so on. So with our first intervention, we want to show you how we approach this complex situation when you work with refugees, but also you use behavior science rapidly. We were lucky to secure partnership and support of different institutions. So on our first request, we got, as I said, excellent team of Bird, Ben, Rai, other colleagues supporting us methodologically. Yale University was ready to provide their expertise on building this experiment, LSE, Duke University, and so on, that Aga will also talk about. That allowed us to launch 4 experiments at the same time on different topics, because you cannot choose between mental health, vaccination, and violence against children. So we decided that we will go with all possible ways to test how we approach refugees. So with the vaccination, as I said, there are numerous barriers that refugees have, and we decided to do 2 interventions. One that would target caregivers, and we can go to the next slide. So we choose 3 frames that we are trying to see if that will increase demand to vaccination among refugees. Will, for example, their trust in Polish health system, which they do trust more than in Ukrainian, will actually affect their behaviors towards vaccination. Potentially another one, if access is difficult and barrier now, we are testing the frame if simplifying the access and explaining that it's pretty easy in Poland, very digitalized, will help them. Or using actually risk aversion towards war and highlighting that during this time when they have so much threats around, vaccination is important than ever, would help. So we are, started with qualitative, quantitative research. Now we are going to the experimental stage. Cannot share with you results yet, but I think they will inform all response countries and potentially can be amplified to other similar contexts when we are speaking about refugees. So we are very excited to see what are the results. And the second one, if we go to the next slide, is interesting. Another way of looking to the experimentation and vaccine demand generation. As Etienne said, it's not about changing actually, sometimes, usually it shouldn't be about, changing people to use their rights. It's about, making it much more easier. In our case, it was about health workers. So we're doing the experiment to see how biases against refugees might affect health workers' ability to provide services, to spend time, which refugees need a little bit extra to usual citizen, to read their vaccination records. So what can facilitate health workers' eagerness to support refugees in getting vaccination? So we already went through the stage of behavioral mapping, qualitative interviews, and we will go to the experimentation stage. And again, we will be happy to share the findings, but we want to show that this is some structure that we use from both sides. And I will pass to my colleague Aga to share 2 more experiments we are doing now.
Thank you so much. And you can go to the next slides. And yes, as Anastasia was mentioning, this is impossible in this refugee context to choose only one priority areas. And mental health is another topic that is very, very important to our team and in the other refugee context. In here, you have the behavior maps that we've developed also with help of the experts in the universities. And you can see that in this path, we want to reach the target behavior, but we have some of the barriers, such as stigma, such as trauma and stresses caused by the war, for the adolescents not to seek the MHPSS services. So with our interventions, with the tests that we are proposing, we want to find the solutions to overcome these barriers and reach the target behavior. With the next slide, we talked about the adolescents, but we also want to work with caregivers, because that impacts also children very, very much. So how we can promote the positive parenting behaviors among the refugee, in the refugee context, among the refugee communities who are here in Poland at this moment. We know that there are some obstacles, such as stress-driven automatic responses, such as social and cultural norms, but we need to find the ways to overcome this. And with behavioral science and with the extensive help of Barry Lab and other colleagues and experts here, we can do it. And with my last slide, if you can switch, we can see that we are just starting these projects, and we can see that there are needs and there is an appetite for the behavioral science. And we're not doing this in silos. We're doing this work with the CSO, with the partners that are working on the ground, and with the universities that have the capacities in the behavioral science interventions, such as Yale, LSE, Duke, or national universities. And what we want to do is to create the Insights Lab that will inform and create more interventions, and we will be able to scale up the work that we are doing right now for the refugee response in Poland. Thank you so much for the opportunity to talk to you today, and over to Rachel.
Thank you so much, Aga and Anna, for sharing this overview of the innovative and important interventions underway in Poland. We really appreciate the spotlight that you've shown on evidence generation through formative research and these really excellent examples of behavioral mapping processes at work. Next, we're joined by Francine Greiner from the Asaro Regional Hub. Francine, over to you.
Thank you, Rachel, for that introduction. So my name is Francine Ganter. I work at the East and Southern Africa Regional Office. East and Southern Africa is home to a great proportion of the world's under-vaccinated children. Of the 12 countries that bear the largest burden of missed children, so-called zero-dose children, 7 of these are in East and Southern Africa. Countries in our region are also regularly facing multiple emergencies. So in addition to outbreaks, we face climate-related disasters, war and conflict, both of which result in migration and internally displaced people. So in this context, of course, we see many competing priorities and scarcity of resources, both human and financial. So what's at the intersection of behavioral science and human-centered design for us? Well, it's the need to understand people and behaviors and to leverage these for better health outcomes within this context that I described. What's our approach for this? Well, we borrow from HCD, Human-Centered Design and Implementation Research, for a very simple framework, which I'm sure is familiar to the audience here today. So that's diagnose, design, implement, and evaluate. So we promote the systematic use of data to inform program activities that contribute to system strengthening and better quality services that are better meeting the needs of the people we want to reach. We, of course, engage across sectors because of the multiple emergencies. Don't forget that. It's really important, with both public and private sector. So across nutrition, maternal, neonatal and child health, education, and then arts and other sectors like that also. We're also using data for learning. So at the regional level, we facilitate the sharing of experiences through our newsletter, which is SBC Works, and that highlights great examples from our region, but also through our ESA Demand Technical Working Group, which involves partners and again tries to leverage learning across sectors and between partners. So let's take a look at the numbers. So looking again at that process, diagnose, design, implement, and evaluate, for just a very quick view on progress. This is the statistics from 2022 and 2023 so far. So all of our UNICEF country offices are supporting governments to conduct assessments that get at understanding the social and behavioral drivers of vaccination, as well as other health behaviors and access to health services. 18 of 21 of our countries are using this evidence generated to guide program planning. And 8 out of 21 countries are applying an HCD approach, so using the UNICEF HCD field guide for improved health and immunization outcomes. And then 7 of our countries are also engaging with the Bird Lab to design behaviorally informed interventions that, again, leverage the data collected in the diagnose stage. Finally, on implement and evaluate, we see some sort of dropout when we get to that stage, where a few of our countries are not yet at the stage of conducting the M&E around interventions that support demand and uptake, but that's something that we are hoping to improve. Our target is, of course, 100% for all our countries to be regularly evaluating interventions, and again, fostering those lessons learned so we can share that with our colleagues and strengthen our approach. Thank you very much.
Thank you too, Francine. It's just so inspiring to see the Asara region's thoughtful and intentional approach to community-led engagement. We really appreciate you being such a shining example of UNICEF principles of nothing about us without us, and also the seamless integration of people-centered research, design, and implementation into all of Asaro's behaviorally informed interventions. And now, as the highlight of today's webinar, we'll turn over to Akiko and Ayub from the Asara region for their spotlight presentation on applied behavioral science in the Kenya country office. Akiko, over to you.
Thank you, Rachel, and thank you for joining us in this session. In this segment, we will present Kenya's approach to zero-dose children living in nomadic communities. I'm Akiko Sakaedani, Social Behavior Change Manager in UNICEF Kenya, and I'm joined by my colleague Ayub Duale, Social Behavior Change Officer. Now let me start by explaining the country context. Next slide, please. Kenya has a population of about 47.6 million, and it has borders with South Sudan, Ethiopia, Uganda, Tanzania, and Somalia. And it has a strong health system with the full immunization of children over 80%. Kenya was among the first to catch up with the immunization after the COVID restriction measures were closed. And then zero-dose children is about 2% at the historic low level. Now, we looked into where those zero-dose children are, and as you can see in the map below, the lowest coverage is along the northeastern borders with Somalia. And children in nomadic communities are the most underserved population. So it's also an area that is exposed to the risk of influx of refugees who have never been vaccinated. So this is the region where we see an outbreak of cholera, polio, yellow fever, and several vaccine preventable diseases. So we looked at the social cultural barriers to vaccination in this part of Kenya. Some settlements are, first of all, not known to the health workers, making it difficult for the health system to do an outreach. And because the connection between the community and the health system is not so good, there's a lack of trust in the health services, and there is also low birth registration rate in this region, making it difficult for the health system also to plan for the immunization of children. There is also insecurity hindering rural travels, both for the community health workers to come to the communities, as well as for the mothers to bring their children to the health centers. And there is also cultural beliefs and practices affecting health-seeking behaviors. And there is impact of climate change, making it difficult for people to make a choice of health over their time of finding water and finding food. Next slide. So we conducted action in 3 phases with the support of Gates Foundation. We created a demand intensification and community engagement project in nomadic communities along the Somali borders. Phase 1 was social mapping of nomadic settlements and point of interest, where we know how to meet people, where to meet people along the borders. Phase 2 was diagnostic human-centered design workshop, planning together with the mothers and fathers and community people on how the intervention should be designed. Phase 3 was applied behavior insights, interventions, and research. This is the next phase. Next slide, please. So in the phase 1, we conducted a social mapping of nomadic settlements and points of interest. Next slide. The first step was planning together with the health facilities and the county health. Together, we looked at the list of villages, and we created the master list of nomadic villages and prepared a questionnaire together. And we secured the budget and conducted the nomadic data collection. So the data collection was about the geopoints where there is a landmark, there's a water point, there is a livestock market, and religious points, schools and health facilities. Those are the places where the pastoral communities will stop by where we can meet with them to conduct vaccination and other outreaches. So those settlements information were collected and the geopoints were coded on the map. And then nomadic profiling was conducted with the data validation and analysis. We had quantitative information and distance to points of interest were recorded, and geovisualization also helped us to know the locations to meet with the nomadic population. Next slide, please. And then we conducted the community engagement, what we call the whole of community approach. So instead of health workers just visiting the families with the vaccination, we engaged all the community champions in the community, including 66 nomadic champions, 45 Tutsi religious teachers, 42 mothers groups, 32 shopkeepers, 199 nomadic mobilizers and nomadic informants, elders, and 66 transport providers for road safety, and 33 nomadic trackers. So all of these people understood and shared the objectives of the project, and we conducted a community engagement together. Next. So the result was remarkable. So we had health education reaching 66,400 adults and childhood immunization of more than 7,000 children vaccinated from 0 dose. And then we conducted also treatment for minor ailments that benefited 46,800 people. And more than 3,300 children were treated for malnutrition. And this was really life-saving because Kenya was experiencing the worst drought in 40 years. We also reached pregnant mothers with antenatal care. More than 3,200 women were reached. So by moving from polio-only approach to this integrated approach, we were able to win the heart of the population, and the health workers were able to win the trust of the community. And we created unprecedented demand for immunization services. We had shared understanding of the importance of preventive health in the community and the community trust in the health services. And these were the key currencies that we used to bring us to the next phase. Next slide, please. I'm going to hand over to my colleague Ayub for explaining phase 2.
Yeah, Kiko. So from what we had in terms of phase 1, then we moved off a kind of phase 2 in which we did the human-centered design workshop so that we understand more about the nomadic population. Next slide. So for us, a key project objective is actually to build a community-led engagement into our projects. So this project led us to apply diagnostic human-centered design for phase 2 programming. Towards this, we held 2 workshops with community representation led by UNICEF KCO and supported by Nucleus International. We collected insights and we grouped this insight into different thematic areas, such as which ideas and insights can work on pre-mobilization and outreach gaps, and what can work on advocacy level. So further to this, we also done a small expert kind of a review meeting in Nairobi so that we can use this information now from HCD towards behavioral insight. Next slide, please. So usually in human-centered design approach, prior to every HCD workshop, it is good always you provide your personas, the people you think have a role to play in immunization journey for a nomadic child. However, during our rapid inquiry phase of the real HCD workshop, we actually learned more than we knew about our main persona, who is this nomadic mother, who is currently not completing timely the immunization schedule. So using the persona template, we got a clue into her daily life, the environment she lives, the time, and what her basic needs look like, and even her primary influencers. So next slide, please. So we managed to collect and come up with the key barriers towards what is ailing the mother not able to complete the immunization journey. And the immunization journey for a nomadic child is not one without a lot of barriers. So at individual level, some things like forgetting the immunization schedule and the illiteracy level of the mother popped up. And if the mother intends to travel again, there are a lot of issues preventing her from doing this. The means may not be possible, insecurity may be rampant, and so many other things. And then if she has the intention and the means, again, sometimes the financial issues come to block that intention. And because mainly women have low economic power and they may require even permission to access financial services. At the health facility level, again, you may find that the schedule is not well planned. The health workers may have moved to another outreach site. When she comes, no one is around. So next slide. So in the previous slide, as we have seen, when it comes to seeking immunization, we have the main person who is the mother, but is influenced by the peer networks and the husband and the transport provider. However, we can extend this influence by noting that there are other key stakeholders, such as the religious leaders, the water point attendants, the security organs, who have all a role to actually facilitate immunization uptake. Next slide. So all this information that we have collected now took us to the 3rd phase of our programming, where we now want to use all the insights we have collected into kind of a behavioral insight intervention and a research phase. Next slide. So currently, the government of Kenya has a recommended immunization schedule, which requires the mother to visit at least 6 times on these timelines highlighted in the screen for the child to complete his immunization. So towards this, we will conduct outreaches, but now we want to change from that behavior whereby now it is the mother who will initiate the travel and visit the nearest health facility instead of us doing an outreach. Because outreach sometimes is funded by partners, and if it's no longer there, we will continue to have zero-dose communities in those areas because outreach somehow may not be sustainable. Next slide. So learning from our HCD exercise that we have conducted in 2 counties in Kenya, we have gotten the insights, and we hope to apply some of the concepts from the behavioral science. This may include the cognitive issues, the reminders, social norms, and the issues of incentives. Next slide. So in this phase, we will double our efforts to renew and understand more about our nomadic population using experimental design. Next. So what are we using from behavioral, and in terms of intervention, what are we looking at? We will be having, we'll be employing, first of all, the COMPI model, and I hope we know the COMPI model. So the model has various approaches. It looks at the capability of the person, the opportunities that's available, and the motivations that can be provided to facilitate the behavior. So this intervention is what we want to give to our nomadic mother. So in terms of capability, we want them to listen to the religious leaders and to feel comfortable that they can engage in this behavior. So there will be some sermons on every Friday prayer, and the sermons will be mainly tailored toward making the visits and being something accountable, and so that the mother and the father, both of them, look towards fulfilling that role. At opportunity, we want to create around a joint travel norm from the health from the settlements towards the nearest health facility by organizing a pickup sessions for the mothers, whereby if they group themselves and come up with on their own using locally available means, we will subsidize the cost for that collective trip. And this will, of course, improve social norms, reduce the cognitive burden of will there be a transport available for me and something like that. So when you end up and visit the health facility and you provide, you immunize your child, of course, we will gonna give you some variable reward, and variable is that we will be changing the reward every time and then. Next slide. So we will have cluster randomization at health facility level, and we will be using 18 health facilities. 9 of them will be treatment group, and 9 health facilities will act as a control. And we will have various sources of information to measure our progress. And in the next slide, we have some good stories that we have done previously. I hope you'll be able to see them. We have a video, and we have 2 good web stories regarding our previous phases. Thank you for joining us, and we look forward to explain more in the chat, and thank you so much.
The nomadic people have a unique challenge because those people, the way of life is unique. Because these people are people who are shifting from place to place. And they are shifting because they're looking for pastures for their animals. And the children and the mothers are without animals. Whenever we reach to those people, we might even see a child of 3 years, 4 years, which has never got an antigen, which is very risky.
أنا أفر 20 جري يا حنون كنوا يقصد وقت مال باديو أو إسبتال عن لقى قانين نواجه تلال لما قبل حنون كمركا إلا 6 سنة يوي هاي هو سرنا وصرنا مركا دمان إلهي يقول عافيه ونكون نافوي أقول لها الساحة دي يقول علي أو نافوي وحي عن قبسين جري أما ماشي عن مري جري من مركري حتى أنا أنتاجنا هاي مركا هذه لنا فن ينين اللي حاد غبا سكسي واحد ما قبصنا يا سأل أوجد مركا قابتي
Before the DICE project, there was a difficulty because we have never came and talked to the community leaders, we have never talked to youth. But since the project started of DICE, you will never get a zero dose child in this center.
The peculiar thing with these 2 sub-counties is that they are bordering the neighboring countries of Somalia. So the pastoralists have no borders. They don't differentiate between Kenya and Somalia, they move from place to place. So the project came in handy so that at least it's improved immunization in the 2 sub-counties.
waxaan ugu sheegayaa masaajidkan ka wacdina ugu sheegayaa meelaha ay biyaha ka cabaan baan ugu sheegayaa meesha daaqa joogan meel alla isku imaadan ay ugu sheegayaa wixii aniga saan u fahansanahay intaan diinta ka fahansanahay aan leenahay culummo waxa ay ka qabtaan malaha wax alla wixii caafimaad waxaa ka mid ah tallaalka oo aad u qaadanayaan oy bulshadii fahantay ayaa ka mid ah oy ka heleen warqadihii dhalashadana ay ka heleen ay ku qaateen ayaa ka mid ah way jiraan waxyaala mala abuur leh tallaalka laga sheega way jiraan laakiin waxaan kaga hortagnaa waxaa ka mid ah ilmaha haddii laga duro sinta way naafobayaan ilcaanta haddii la duro garba laga duro marashay noqonayaan waxyaalahaas ayaa ka mid ah laakiin waxaan naga hortagnaa waxyaalaha diinta ay ka qabto caafimaadka ayaan ku wacdigelinaa bulshada.
Through the DICE project, we were able to immunize more than 7,000 children and 3,217 pregnant mothers were given ANC services. More than 57,000 were reached with immunization messages. 85,000 were treated for minor ailments. More than 5,000 treated for severe and moderate malnutrition.
Wonderful. Thanks so much, both Akiko and Ayub, for a really compelling presentation and for the impactful work you do at the intersection of behavioral science and HCD in general. I'd like to take this moment to turn us over to our co-host. Joining us today is our colleague, Ellen Elizabeth Moscow from the World Bank's Embed Unit. Hi, Ellen.
Hello.
Would love to turn over to you for any insights and questions you may have for today's panelists. But first, a quick question for you. As we progress through today's presentations, our UNICEF colleagues overviewed their current approaches and strategic visions for applied behavioral science and practice. But we know that as behavioral scientists, the discipline continues to evolve with new innovations and insights being put into practice all the time. And embedding and mainstreaming behavioral science at the institutional level, it can take lots of different shapes and forms. So can you tell us a bit about Embed's approach to applied behavioral science? And please feel free to share any case studies or examples that you'd like to at the intersection of BI and health. So Ellen, over to you.
Thanks. Thank you everyone who's joining today and to all of the previous speakers. As Ray said, my name is Ellen. I'm a member of the Mind, Behavior, and Development Unit at the World Bank, and we sit in the World Bank's Poverty and Equity Global Practice. And we apply our mandate, I guess, is pretty broad, which is to apply behavioral insights to development challenges across the World Bank's regions and practice areas. And we're a relatively new, to the bank, we're relatively new. The team started up after the 2016 World Development Report. And so right now we're sort of at a stage of growth where this type of question is actually very relevant. We have historically had a very diverse set of models of how we apply behavioral science, everything from having, just offering some just-in-time support and technical assistance to governments, to a model where we would really embed ourselves from the beginning of a World Bank operation and bring some expertise to the diagnosis and development of a program, and bring this behavioral lens from all the way from the conception of the project through to the end. And then we also do primary research, policy driven, of course, but research that looks much more like a policy relevant academic style approach. And as we've grown, we've found that there's a lot of value in this, in the projects where we can come in from the beginning. So where, teams, country teams within the bank or subject area experts together with the client countries have some target that they're trying to attain. And we know that in a lot of these, there's always going to be a role for behavior, whether it's the end user or whether it's often on the supply side of, for example, health workers. And so I think where we've been able to be the most impactful is when we really come in from the beginning. And so, of course, it's tricky, as anyone at UNICEF probably knows. These like large organizations can be it can be hard to kind of figure out how to do that practically. And but I think we try as much as possible to come in at the earliest stage feasible, so that we're there to support not only kind of these final tweaks at the end, but really the conception of how these programs are going to work. I think if it's okay with you, I might just jump into a few thoughts from the presentations.
Perfect.
Okay, so I have two sort of comments on one on the Poland vaccine work and one on the Kenya case study that I'd like to sort of toss out there, maybe to start the discussion. And then a question that's maybe more targeted to Ben, which might be thinking more about how you're deciding which projects to get involved in, as a new group that could potentially grow in many different ways. Wondering how you're thinking about kind of the trade-off between focusing on sort of individual behaviors versus more structural barriers, as some people in the chat also mentioned. And then also thinking about where there are opportunities for systems level behavioral approaches. So intervening with health workers, or thinking about the design of program delivery channels, or potentially even intervening on kind of the mindsets and behavioral orientation of policymakers themselves. So I think if we have time, Ben, if you want to speak to that. And then, so one thing that came up when I was listening to the COVID vaccine, or not COVID vaccine, but the vaccine presentation from Poland, is that we've done a bit of similar work on COVID vaccine perceptions, and found that that these type of framings can be effective in shifting people's intentions. But I was wondering if you've thought at all about how to pair this with some supply side interventions. Like, I think it's great to think about the journey map on the side of the practitioners, but also what about the vaccine delivery systems themselves, whether there's any scope to work with that, and whether, sort of whether how the team has been thinking about that challenge. And then one question to bring to the Kenya case study is that I think some other people also mentioned in the chat that behavioral science can feel a little bit sometimes like it's targeting individuals who need to change, as opposed to targeting a system that needs to adapt to people. But we can also think about a third factor here, which is other actors who are in the communities surrounding kind of our target populations, and how how addressing them can relax some constraints on our target populations. And I think this is a great example, because many of the barriers that were identified focus really on women's time constraints, on mobility constraints, on caregiving burden. And I wonder if there's a role there, or how the team has been thinking about the role, for example, of the imams and religious leaders and other community leaders, to actually directly intervene with the fathers and other family members to say, we need your support here. If the mothers are going to be able to go and take their children for vaccination, you have to let them go do that. You have to enable them, you have to give them time. And so how can we kind of think about the role of norms in the society that can indirectly relax some of these constraints that the women are facing. And so I thought that was an interesting dimension that came up for me in that presentation. It would be great to hear some responses.
That's great, Ellen. Thanks for these really thoughtful questions. What I might propose is let's start with our Kenya office team on how we intervene with communities surrounding our key actors, and then let's shift over to Anna on the systems delivery question, and then finally to Ben. Colleagues, does that process work well for all of you? Great, so Akiko or perfect, over to you.
So maybe the question in terms of the key actors that we are trying to propose to use in this journey is actually looking at the role as a social norm instead of individual norm. In the nomadic setup, the community is the key group as a whole that can be used to really motivate the caregivers, specifically the nomadic mothers. So by doing so, when, for example, the respected, you'll find the nomadic settlements, there's a duxi, and in this duxi, there's a religious leader. This leader is the one who controls much of the interventions around religion, and they listen more. And majority of the fathers who may not have time to listen to anyone at that time, they are available during the Friday sermons. And therefore, these topics that is geared toward them will, of course, be a motivating factor. And we hope to use this now to nudge them to motivate the caregiver, specifically the mother, so that she makes this journey. I hope I've answered, but over to Akiko for any addition.
Nothing to add from my side. Over.
Wonderful. Thank you so much, colleagues. And now I'd love to turn over to Anastasia and Aga from the Poland team. In addition to Ellen's wonderful question, we also had a question from the audience that you may wish to respond to. Specifically, if you found any challenges in balancing rapid design and research against academic rigor and longer timescales that we often find in behavioral science research. So Anna and Aga, over to you for those two questions, and then we'll turn back over to Ben to close us for the day. Over to you, ladies.
Thank you so much. First of all, very inspired by nomadic case from Kenya. Amazing work. We had the same situation in Ghana. We would love to learn from your experience on the insights of nomadic community. On Poland side, I will start and Aga maybe will continue. We do need to do a lot of compromises, to be honest. For example, power analysis showed one sample which is not realistic even to find. And communities are always moving back to Ukraine or come back to Poland. So to have a fixed size sample that will give us a proper effect size is extremely difficult. So that's, of course, ethical approval, we are lucky to have partners that are quite fast. But again, now they're on holidays, and this is normal. Academia is on holidays, so ethical approval is delayed. And we are speaking about refugees that potentially, not dying on the street, but still facing challenges in accessing vaccination and having demand to vaccination. So there are compromises and barriers, but we are still very, very lucky with the environment. This all can be facilitated. We have partners, we see how we can mitigate these risks, and we will reflect it in our limitations. And then, data collection. Again, we are lucky to have quite a digitalized society where, for example, in Ghana, we were really, really creative on how we can do rapid experimentation, but with the communities that don't have access to digital. So we, for example, did it through SMS. With the second question on supply side, of course, again, lucky to have enough of vaccines, but not lucky with having communities that would rather call their doctor in Ukraine than go to the doctor in Poland because of language issue, because of, not being registered, because they simply don't know where to go. There are so many facilities which would overwhelm refugees in Poland. Also, it's very, very comfortable environment. So on the supply side, you're right. We did like mobile vans that go across the cities and inform people. We are adding pediatricians consultations to all our refugee accommodation centers where they can provide advice. But simple thing as Ukrainian text of vaccination records, even this prevents refugees to access vaccination because it's difficult to read Cyrillic versus, Latinitsa, and it does require time. And again, we know with you that a pediatrician usually would spend 7 minutes with a family, have 7 minutes with the family. And if you need to extend it to 13, that's already end of vaccination. That's, research that was conducted, for example, in France. Yes, just a couple of additional minutes that will allow therapists to give vaccination, proper consultation is not something that any pediatrician can allow themselves. So this system should be changed. That's why we are looking also to healthcare providers. And Aga, what is your reflection maybe on the system side? What can be improved?
Yeah, thank you so much. And thank you for this question. This is really something that we've been discussing in our team a lot. And I think we are in this particular setting very lucky, as Anastasia was mentioning, to be able to work with the partners that already have the capacity, that already, for example, work with the health workers, that have some of the research background. So first of all, I think we need to build capacity. This is something that for example, as now we're having this conference, we're talking with you, we're talking with experts about the possible solution. We need to keep on sharing this and trying to think how we can scale up and how to bring the partners up to speed with the research, with the interventions that we're doing from the very beginning, so they understand the whole process and can help us implement them. But thank you so much for the questions and for presenting today. Over to Rachel.
Thank you both so much, Anastasia and Aga, both for a fantastic presentation and for these really thoughtful responses as well. To close our session today, I'd like to turn back over to Ben, both to answer the insights and inquiries from our co-host Ellen, and then just for your final thoughts as well. Ben, back over to you.
Thanks, Ray, and thanks, Ellen. Thank you so much, colleagues. After like a 13+ hour day, this was a much needed reminder of why I love my job so much, how much I love my colleagues, how important the work we do is, and I really believe it. Ellen, I think I forgot some of your questions because you had a few really good ones, and I remember getting quite excited and thinking it would be impossible to answer in 30 seconds. Luckily, they're letting us go a little bit long. I have no idea if anybody's still watching, but I think one of your questions was like, how do you decide which country teams to support and which projects to prioritize? Usually what you're looking for, like the necessary, but of course not sufficient condition, is you're looking for government buy-in and a local champion in the UNICEF country office, somebody who really is looking for new tools or approaches to make change. Maybe they feel like there's an opportunity here, or they feel stuck and they reach out, and but it's just the beginning of a conversation usually. And then that's when we start to talk about, well, what level ought we be focusing on given the nature of the problem that they're describing or they're trying to tackle. And I will say, I would say more than half of the ongoing engagements with country offices are not just focusing on changing people's minds. It's certainly not just focusing on caregivers and getting them to come and vaccinate their kids. It's making adjustments to how services are delivered. So I think the work with the nomadic populations is actually a great example. Also the work in Poland. I mean, in many cases, the challenge is on the service delivery side. It's health workers have really difficult jobs. Small changes in the environment that they work in, small changes in the design of their workflow and how their days are structured, giving them opportunities to have the kind of conversations they need with caregivers. Those are where a lot of our solutions are landing. But of course, you can't go in thinking that you know with a bunch of assumptions about where the solutions will be. We go in with a wide aperture. We go in without assuming that you're going to inform, educate, and communicate your way out of it, or that it's just about changing the minds of the caregivers. We really use a lot of different tools: power mapping, network mapping, journey mapping, habit mapping, and try to pull all of those insights together to come to a systems view of the problem space, and then use that to design what is usually often kind of a system of solutions. It's usually multi-pronged. It has a few different elements and it works on a few different layers or levels of the system. But yeah, you got to know that you got to go to the right level to make the change. that is it's sort of one of the core principles, I would say, in terms of the way we approach our work. But I don't think we've ever said no to any country office that really wants to do something. I think we've always tried to find a way.
We'll be following your work and interested to see where, you know, what the results of some of these projects that were presented today. Thank you.
Yes, same. And it's, I got to figure out what's an elegant way to wrap this up. I mean, Ray, I know you'll know how to land it all, but you know, I'm following it too. And it goes back to this question of long-term versus short-term, and how much emphasis do we put on documenting and sharing out and telling great stories versus like just getting the work done, because all of our people are working so hard. And that's the majority of how we spend our time. So how you package it and communicate it, you know, we're starting to realize how important that is as well. And this is something I think at a global level that we're hoping this idea of a bird lab can help take some of the burden off our regional and country teams and make it a little bit easier to just showcase good work that they're doing and facilitate sharing between one another so that other country teams feel empowered, like this is something that they could do, so that they understand that this is not, you know, as difficult or intimidating as perhaps it sounds on paper. And this is sort of what we're trying to do. So to be continued. I wish we had more time. Next time, let's make it longer and more dialogue and discussion.
Thanks so much, Ben. And what a great way to close. It really is a community of actors coming together, learning, growing, and applying behavioral science, both in core ways and in our own unique ways for each region and each country office, so that their perspectives really shine through in our process and methodology. I do want to thank each of our regional office, country office, and Bird Lab members for joining us today, and a special thanks to Ellen from Embed for joining us and sharing her wonderful insights. We thank our audience as well for joining us. And please reach out. The presentations will be available online soon. Check out the Bird Lab website. We also have direct emails for our different colleagues embedded into the presentation, so feel free to reach out to them as well with your follow-ups. And just thank you all for a wonderful, engaging webinar today. Thank you all so much. And I think that's it for us today. Take care, everyone.